Recording. Okay. So I do want to take this time to welcome everyone this evening, and on behalf of the UMDS staff and board, we'd like to wish you all a very happy and healthy Thanksgiving with your family and friends this week. We are thrilled to kick off this holiday week with Dr. Amy Goldstein from Children's Hospital of Philadelphia and Dr. Steve Lobel from the Medical Associates of North Georgia and Canton, Georgia. And thank you both for taking time out of your busy schedules this week. Dr. Lobel is board certified in physical medicine and rehabilitation and pain medicine, and has followed the care of many of our patients in Georgia. And of course, Dr. Goldstein is a longtime, well-respected clinician and speaker in the mitochondrial community. Tonight, they will be covering a topic very near and dear to our mitochondrial patient community, it is pain management. So thank you both. Again, you may begin when you are ready, doctors.
Kara, can you hear me okay?
Yep, we can hear you.
And then are we on video right now or no?
You are. I can take you off video.
No, that's fine. I just wasn't sure if I should be looking at the camera or not. And so what we see right now is the lecture, the lecture's title slide. So I just wanted to say hello, and I'm not going to speak a lot about mitochondrial disease because I would like to have the time available for Dr. Lobel to go through some background about pain, and then of course we're really here to take everyone's questions and provide some answers. But I just wanted to start off by saying that we know that many patients, especially the adults, have different pain issues. I think that as clinicians, we are still not capturing all of that. And I was just reviewing one of my colleagues' papers. There's a very now well-known paper that came out. I believe we published it in 2018. And when I say we, it came out of CHOP. It was my colleagues, Dr. Zol Kipley-Cunningham and Dr. Marnie Falk, reviewed what symptoms are most prevalent in mitochondrial disease and what symptoms would prompt someone to want to go into a clinical trial, what relief are they hoping for. And pain as a general topic is not covered. Peripheral neuropathy is covered and headache is covered. But of course we know through talking to our patients in clinic that there may be headaches, there may be abdominal pain, there may be muscle spasms. And these are things that really can affect quality of life. It can affect your sleep. It can affect your ability to exercise. And as a neurology trained physician, we don't get a lot of training in pain, although a lot of the drugs that I use, the medications that I prescribe for seizures or for headache may also have some secondary benefits. But I think what we're really trained to do is ascertain whether someone's having pain and then refer them to a pain clinic. So I wanted to invite Dr. Lobel to give this talk with me so that we can talk about what does that mean to go see either a pain clinic or a pain doctor, and what's the current state of the art in pain management, and what about all the other new medications we're hearing about and what kind of pitfalls to avoid. So I'm going to turn this over to him so he can go through his slides, and then as I said, we'll open this up to question and answers. Dr. Lobel.
Thank you. So my slide deck is pared down to about 23 slides. It was a lecture I prepared for oromaxillofacial surgeons as part of CME for them. And it was a 3-hour lecture, all encompassing on interventional care and all the different medications and issues prescribing controlled substances and non-controlled substances. And so this lecture is pared down. It is not exactly a patient-friendly lecture. So some stuff will get glossed over. If there's a way to stop me during this, someone will have questions, or if we generate questions, I don't have a problem going off on 1,000 tangents to cover what is needed. Half of my job is poking people in the right places for their conditions. For mitochondrial disease and peripheral neuropathy, there is no interventional care that is appropriate. So this lecture has to be geared towards what else is there besides putting a needle in the body or putting a device in the body to make something better when that hasn't been proven. And a large focus gets into what medications are going to be helpful without too many side effects to be worth taking. And so let's just get moving on with the lecture. I'm going to try and scroll through a slide, and there's a little bit of lag on my screen, so I may have done it or I may not have. And if I didn't, I'm going to try again. Otherwise, Kara may help us move to the next slide. So I'm going to try and scroll or click. I gave a click and so far nothing's happening. So I'm going to scroll and see if that does anything. And I'm 0 for 2. And if I hit the arrow button, I think Kara helped me out there. So this is good. I can see on there, why me? Is that the correct slide, Kara? If everyone, all right, that's the first slide is on my screen. I'm hoping to just hit the second slide. Thank you. So this is a why me slide. If everyone can see that, it's my training, physical medicine rehabilitation, doctors for function, and doctors for patients with disability. It's how to get people doing the best they can with their lot in life. Whatever body you got, we're going to make the best out of it. So that could be peripheral neuropathy, brain injury, spinal cord injury, people who have had strokes and amputations. That's my base training. I then did a fellowship at Emory in pain medicine. And then I became the consultant to the medical board and big government in assisting doctors in losing their license or keeping their license, depending on how they were prescribing. So I'm expert in all things controlled substance, and I like talking about that, and I can go on for days, but we're gearing this towards mitochondrial disease, peripheral neuropathy, and what ought to be done from a patient standpoint. So let's go to that next slide, and I won't hit a button. I'll see if Kara can help. There we go. So we like to think, well, what is pain? And there's just a definition on the screen. This is the International Association, the study of pain. And basically it's whatever the patient says it is. It's purely subjective. So when you say it hurts and it's numbness and tingling, I don't know what that means other than, oh, like when I come in from a frostbite and my foot's waking up, then maybe that's the numbness and tingling, or the pins and needles. Or you cross your leg too long and it fell asleep and it's waking up, that kind of pain. Or you hit your funny bone. You have to go with an example that would be common among people. Otherwise, it doesn't mean it. Well, is it stabbing, aching, burning? That's whatever you say it is. The intensity of pain, whatever you say it is. I could get a bruise and start crying and it's 10 out of 10. And other people get their arm cut off and they'll say, just a scratch. Next slide, please. So I have part of a 3-lecture series, which are an hour each, and we are deleting most of those slides as it relates to legal and regulatory stuff. But I'll talk about opiates because it's a hot topic, because you can't read a newspaper or put on the news and not hear about an opiate epidemic, which really is a bunch of governmental and media interference in healthcare, which is a bunch of nonsense for the most part. And I say that as an expert in pain medicine. I have colleagues and friends who completely disagree with me on the topic, saying it's all the doctor's fault. That's not true, and we have the literature to prove it. We'll talk about the alternatives to using opiates or in conjunction with, because the more things you bring to the table to treat somebody's pain, the better off you're going to get them functionally. Current state of affairs we'll leave out of this because that's legal, regulatory, state-specific for doctors. Next slide. The pendulum swings on opiates. So this is kind of interesting. If we could hit that next slide. We go back to about the 1800s, 1880s. What are pain medicines? Is it just legalized heroin? What are the risks and benefits of prescribing medicine? How do you show that your patient is doing better rather than just saying they hurt less when it's purely subjective? What about abuse, addiction, and diversion, or someone getting medicine to sell, or it gets stolen from the patient and sold? That's the one place we can find fault with doctors: over-treating pain, too many pills, too many prescriptions. Well, if the patient doesn't take them, where do they go? They can wind up with family and friends. And 75% of the time when someone becomes an addict, they may have gotten started by stealing someone's medicine or taking them, stealing them, when they should not have. Big issue we have to deal with is side effects, and we'll talk about that in the question and answer part. They talk about the World Health Organization step ladder for pain. Try a Tylenol, then go to the next strongest medicine, then the next strongest medicine. You probably need to pick what's best for your patient at that time. A lot of the trouble for the government blaming doctors started with the government saying in the VA hospitals. Pain is the fifth vital sign, and it needs to be recorded, and you shouldn't send anyone home from the hospital until their pain is 4 out of 10 in intensity. Well, pain is a subjective phenomenon. How do we 4 out of 10? So if someone wants to stay for the weekend and not go home, my pain's a 5, can't go home. So a lot of nonsense out there. Next slide. This is a quick list. This is pretty much all the prescription pain medicines out there. The ones in red are not for your regular doctors to prescribe or for anybody to prescribe, though they're out there. And I like to start at the top with Ultram or Tramadol. It is a scheduled drug. It is in the opiate family, but it is not a traditional opiate, and people should not be afraid of it. It should be prescribed more freely and taken more often. It works more like an antidepressant, like the drug Cymbalta, in treating pain more than hydrocodone or oxycodone, your traditional post-operative or breakthrough pain medicines. And then there's lots of other choices. There's more addicting and less addicting pain medicines. And then there's medicines just too dangerous for prescribing. I believe that would be Demerol, Methadone, Stadol, and Talwin. Suboxone is a drug just for addiction, but Butrans and Belbuca are oral forms of Suboxone. Belbuca goes into the cheek as a sticker. Butrans is a patch. Same chemical drug, both indicated for pain, when Suboxone is indicated only for addiction, and it can be used off-label for pain. So there's social connotation to your choice of drug. If you look, fentanyl is listed up there. People who hear fentanyl these days are getting the street version made in China, smuggled through Mexico with lots of impurities. Some of the impurities are 1,000 times stronger than fentanyl. If you touch them, you're dead in 4 minutes. But when it's a prescription grade fentanyl in a patch, it's a safe and very effective drug. Almost no one prescribes it these days except for end-of-life cancer care because of the news. That's a basic on opiates. Let's hit the next slide. Talk more about this Tramadol stuff. So the slide's interesting because it's very medical, talking about mu binding and liver enzymes and metabolites. Know this, it's 1/6000th as strong as morphine, binding to the morphine receptor on the brain and spinal cord. If it's 1/6000th as strong, there's no way it works as a pain medicine as an opiate. However, the metabolite is active, so it stays in the body and it's processed to another drug, which is 1/20th as strong as morphine, which means it's still weaker than codeine. So it is still not a very strong opiate as a metabolite. Overdose is rare. It has been reported. If someone overdoses on Tramadol, more likely they'll wind up with seizures than to stop breathing. The dreaded side effect complication of overdose on pain medicine is it suppresses your breathing, you stop breathing and die. So when someone comes in, and we'll go right to a side effect, oh, it's making me short of breath. As a pain physician, we look at the patient and we smile and we say, that's great, you read something somewhere, but no one says it makes them short of breath. If someone overdoses on a pain medicine, they say, I'm just a little bit tired, I'm gonna go lie down. That's how you know they're about to die. And so when someone comes in short of breath, they read the package insert and we move on. But Tramadol is so weak as an opiate that it does not kill you by blocking your breathing reflexes. And so it works more like Cymbalta, serotonin or epinephrine. It's an antidepressant type painkiller. It has an antidepressant type side effect profile, and it has an antidepressant type withdrawal, very similar to Cymbalta, not an opiate withdrawal if someone were on it and stopped taking it. And so it's a very safe medicine. I like it ahead of any of the anti-inflammatories. Aleve or Motrin are second or third line drugs, especially compared to Tramadol, because I treat some sick people and a lot of very old people where if they take anti-inflammatories, it becomes very dangerous. And we'll talk about that in a minute. There's a similar drug that I mentioned at the bottom of the slide called Nucynta. It unfortunately came to market probably 10 years ago when the opiate epidemic was really getting kicked off in the media and news. It was slapped with a Schedule II label from the DEA, and that means it is in the same category as morphine and Dilaudid and oxycodone and now hydrocodone, but it's 1/17th as strong as morphine, so it's still weaker than codeine as a pain medicine, but it does a great job on serotonin or epinephrine. It works really well. And I'm aware of one overdose case when someone injected it and didn't swallow pills. So that was a complete substance abuse issue. Still not going to kill you with a respiratory depression. Next slide. There's a drug Tresix, which is pretty new. It's called dihydrocodeine. So it's not codeine and it's not hydrocodone. Of course, it was just remarketed by, I guess, Razor Pharmaceuticals, but it came out in 1911. And so it's a great drug that can be called in. If you look at what else is in it, it has Tylenol and caffeine, only 30 milligrams. So for some people, they have to be careful. For other people, it's not sedating because it has a little bit of caffeine. And being a Schedule III drug, it's something that is a little easier to prescribe for non-pain physicians. Of course, no one's ever heard of it unless you're a pain physician because they're not allowed to market except to pain doctors. Next slide. Talon and Stadol, I'll just say that, wow, no one really prescribes these that I'm aware of. In my slide, Stadol is used in OB-GYN in the hospital. Neurology used to use Stadol and Talwin NX for headaches in the past, and I'm not aware of anybody in their current practice using those medications. So they're just mentioned because they're good at getting people high, but clinically useless. Next slide. So we talk about the opiate epidemic, and I'll be brief here because it's not that important. Morphine's been around since 1817 on the market. It was used extensively in the 1850s to 1900. Women became addicted because it was given to quiet children, and hysteria, which means anytime a woman complained of anything, their male doctor would say, penicillin hasn't been invented yet, have morphine. And so back in the 1880s, there were 200,000 opiate addicts in the US, 3/4 of which were women. Pretty sad, but that was the start of the opiate epidemic. Next slide. We came out with a great drug. Well, in 1874, it was synthesized and it was marketed by Bayer, 1898 to 1910. Of course, that's heroin. A lot of people don't realize that was a prescription drug from the aspirin people. Went off the market in 1924. It was used to treat cough initially, and then it was there to help people get off of morphine. And what they didn't realize at the time, because the testing wasn't there, the way it gets into the body and gets to the brain is faster than any other drug, much more addicting than morphine. So an interesting drug, whoops, big mistake, and they fixed it by banning it in 1924. Of course, once something's synthesized, you can't get that cow back in the barn. Next slide. So interesting about our opiate epidemic, if you look at the data that I present here, there were percentage-wise many more addicts in 1880 than there are today. It was 1.7% of the US population in 1880, it's 0.78% currently, which means we've had a 54% reduction in addiction rate from 1880 to 2015. We've been doing phenomenally well at limiting addiction as a percentage of the population. And that's what no one talks about. They just say, well, we need to talk about something to distract the populace. And this will be, let's create an opiate epidemic and get it into the media and cause lots of problems for lots of people. And next slide. So here's just one of those nice old drawings. There's the opium on the table and trying to console the cranky child. Next slide. Again, this was a quote from a medical journal in red at the bottom. And it's the opiate epidemic started in the 1880s and it continues today, although things are better now than they were over 100 years ago. Next slide. So what else do we have? Because not every pain is indicating a need for a narcotic. There are lots of other things out there. There are people who have too much risk for narcotic therapy and they should never be prescribed it. So you need the right diagnosis, the right patient with the least amount of risk factors, and someone who's willing to take a medicine that socially at this time is essentially unacceptable. And so that's the narcotic side. So what else do we have? Lots of other medicines, procedures which are not effective for most of the pains that we see in mitochondrial disease. However, mitochondrial patients also have other diseases. I have a nice mitochondrial patient in Georgia who has lumbar radiculopathy. She's got a pinched nerve in her back, and it hurts in her back down the leg. Epidurals help her pain because a disc is near a nerve, but it has nothing to do with mitochondrial disease. Apparently, mitochondrial patients can get diabetes, they probably get pneumonia, high blood pressure, all kinds of other things that need treatment. And so it's not, oh, you have mitochondrial disease, that's it, it's over. There's a whole person attached to that disease, and you got to look at everything else going on. And then there's this complementary alternative medicine stuff that people really get into and they get passionate about, and that includes chiropractic care, cupping, all sorts of weird therapies, Reiki, therapeutic touch, hypnosis, acupuncture, if I didn't mention it. There's a lot of neat things out there that aren't based in reality or science, and so it's hard to say when we look at studies, well, what happened here, and do we believe this information? As medical doctors, our job is to sort the best science based on reality and provide that advice. Next slide. So there's lots of medicines, and the main classes: anti-inflammatories, muscle relaxers, anti-epileptic drugs, antidepressants, and the opiates, which we talked about. And if you look at the list of medicines there, you say, well, I've seen a lot of these things. The one thing I put in red, topical anti-inflammatories. I'm a huge fan of a triple cream, and triple cream will have lidocaine or topical anesthetic, anti-inflammatory, which is ketoprofen, trolamine, mostly any of the salicylates, although I don't like the methyl salicylate or menthols because they burn and are irritating. And I like the drug DMSO, dimethyl sulfoxide, typically not for human use because it's horse liniment, but there is a prescription drug on the market called Pennsaid, which uses DMSO, and it's basically DMSO and Voltaren gel, or diclofenac, which is a topical. All of the topical preparations that I've recommended in the past, I've now discarded because there's been a lot of shady pharmacies making compounded drugs and ripping everybody off for hundreds of dollars or thousands of dollars, depending on who was paying, whether it's a patient or an insurance company. I now recommend DMSO, trolamine, and lidocaine, and these are all over the counter. So for 20 bucks, you can make 12 ounces of medicine, which will last a few months. And I rub it all over my knees and Achilles tendons because I get sore when I go jogging. So I treat myself with this. I recommend it to patients. It's just too easy to use, and it's good for nerve pain, muscle pain, joint pain. Otherwise, the anti-inflammatories I just don't recommend on a daily basis. They work great, but the side effect profile is less favorable than opiates. Skeletal muscle relaxants, there are doctors who hate them, there are doctors who love them. I look at them as an opiate sparing agent. If someone comes to see me and I can give them a muscle relaxer and a non-controlled drug, rather than saying, well, here, just take this one pill, it's hydrocodone. Well, I think a muscle relaxant is a much better option there from a side effect and risk standpoint. AEDs, and this is the seizure drugs, so we got Lyrica, Neurontin, or gabapentin, Keppra, Lamictal, Tegretol, Trileptal, and 20 or 30 others. One that I don't see on here is alpha-lipoic acid, which I like a lot. And I think the mitochondrial doctor recommends it too. And so that's kind of neat. I probably got that idea from Dr. Goldstein. Antidepressants, the ones that seem to be able to treat pain are the TCAs or tricyclics. That's typically Elavil or Pamelor. Some people will write imipramine or desimipramine. Effexor is very good, but lots of side effects. Cymbalta and Cybella, both indicated for fibromyalgia. Cymbalta is indicated for a ton of other things. And then getting into the opiates, which are much better for nociceptive or mechanical pain rather than nerve pain. They're more last resort for nerve pain after failing lots of other treatments. Next slide. Safety of anti-inflammatories, I won't go into it. I'll just say that roughly 8,000 people die a year from Motrin and similar. They're having heart attacks, strokes, and ulcers. Even though every patient that I see, and I say, oh, you probably shouldn't take that, they go, oh, it's my kidneys and my liver that's in it. No, kidney and liver are really end stage. You're going to have a heart attack. 31% increased risk of a heart attack for people taking Motrin every day. Why is this over the counter? Good question, because it's been over the counter. Next slide. A study by this Gislason guy says, hey, these shouldn't be over the counter. And this was in the UK. And what we find in Europe is that typically Motrin packaging there is 8 to 10 pills. And here, go to Walmart, get 1,000 pills for the cheapest price. And so we've got that issue here, where if you're buying 1,000 pills at a time, or 500 or 100 at a time, you just think it's safer. And that's not the case. One drug I like to single out specifically, diclofenac. It's written by orthopedics predominantly. It's the riskiest of the anti-inflammatories, very much like the drug Vioxx that had to go off the market over 10 years ago because the heart attack and stroke risk is just too high. Next slide. Muscle relaxers, there's a ton out there. I love Xanaflex because it's very good at bedtime because it can augment sleep. It's an anti-spasticity agent. I know there's lots of tone issues and mitochondrial disease, making Xanaflex and baclofen the best choices. Baclofen's a bit less sedating, but has different side effects where too much too soon makes people weaker, which can be kind of scary. Flexeril is just the old standard. It's essentially the antidepressant Elavil, just slightly tweaked. It does not actually relax the muscle. It makes you feel relaxed, and so it works on the brain. Scalaxin is a non-sedating muscle relaxer. Robaxin is the liver-safe muscle relaxer. So if someone's on a lot of medicines that go through the liver or has any liver problems, Robaxin is the choice. Parafon and Norflex are less commonly used. Soma, I don't write for it. It's a barbiturate-like substance. It does not relax muscle. It has its own abuse and addiction potential. It's a dirty old drug, and it should go off the market. Benzodiazepines, not written by pain doctors, or if they are, they shouldn't be. Own abuse potential worse than Soma. Also combined with pain medicine will increase the risk of overdose and death. And so they're not recommended by anybody. All younger doctors are trained not to prescribe them other than for situational anxiety. You gotta get on a plane, here's 2 pills. Gotta get an MRI, here's 2 pills. Need something every day, do not take this drug. Next slide. Adjunct, so here's all of our seizure medicines. Lyrica is probably my go-to, especially now that it is generic. Side effects, some people will get leg swelling, some people will get blurred vision. Beyond that, it's not that bad. Keppra, very few side effects. It's not first or second line because it's usually less effective, but still decent. Topamax is one of my favorites. Headache prophylaxis medicine has the best clinical data for pinched nerves as far as relieving pain in a leg when a nerve is pinched in the back. A bunch of antidepressants, which mentioned before, are very effective in treating nerve pain. For head and neck specific pain, trileptal, Tegretol, Vimpat, and Baclofen, either trileptal or Tegretol plus Baclofen is standard of care. If that fails, Vimpat has a small study saying it can be helpful. I don't have a problem with Fioricet. It's a low-dose barbiturate. Midrin, hard to find. Drug is isometheptine. And the triptans for migraines, again, purview of neurology. So they're more comfortable prescribing or not prescribing those medicines, but I don't have a problem writing any of them. Getting into low-dose naltrexone, LDN. Lots of media out there in the last month or two. In my area in Georgia, one of the compounding pharmacies will make up the dose that the patients want, and they're doing direct-to-consumer advertising because there's some decent studies out of Stanford showing fibromyalgia or any type of pain condition may benefit. Low-dose naltrexone is not just for addiction, where people will take it if someone is overdosing, or it's used to keep people off of alcohol. It's a decent pain medicine. The only known side effect is vivid dreams, and that does not mean nightmares. It just means you'll have better recollection of your dreams, or possibly you'll dream in color if you hadn't before. And so when you tell patients that, everyone's willing to try it. It comes in a 50 milligram. I'll tell patients to break it into quarters and take whatever's left of the quarter they've got in their hands, and that's the starting dose. And that's why I say 4.5 to 12.5 milligrams. I have no idea why 4.5 milligram became the study dose because it's not available commercially. And so next slide. CBD and THC. Geez, everybody wants to know about CBD and THC. And people are like, oh, what about medical marijuana? And they say it half jokingly when they should be saying it fully jokingly. It has been exhaustingly studied and it's completely useless. And so we've got 3 different studies that I put up there, and they're all either large meta-analysis or review of studies or large studies, and all of them come to the same conclusion. The better you study CBD and THC, the more you realize they're useless. They don't do anything. People love to argue that, saying, oh, I need to fine, go to Colorado, go to DC, buy your marijuana and do whatever you want with it. Medically, it's nonsense. It's just a push for people to get it legal in all states for recreational use, which I think is great, but leave the doctor out of it. We've got our data. We know it does nothing. If you say it helps you, get CBD. It's over the counter. There's no downside to CBD. So anyone can use it. It just, if it works for you, great. It's a placebo. If it doesn't work for you, it shouldn't, because it doesn't do anything. And everyone says, oh, I had a friend try it. And it really helped them sleep. It helped their anxiety. It helped their diabetes. It made them taller. It made them younger. It does a lot of interesting things, none of which are scientifically proven. Downside to CBD. Other than it not working, you don't know what you're getting. It's not regulated by the government. So it's $1 billion industry. I could open up a shop, start selling CBD, and get you pieces of chalk that I cut up off the blackboard and label it CBD, and it's CBD as far as you know. 70% of products tested did not have the amount of CBD they said. Some had too much, some had little, and some had none. So if it's not a regulated industry, how do you know where to get CBD? If you're willing to try it, you can go to your vape shop, you can go to your GNC, and it's still a crapshoot. There are certifying agencies that are not the government. The largest is the US Pharmacopoeia. I'm not aware that they do certify any CBD, at least it's not easily accessible on their website, but there are probably some more reliable sources. I can't tell you who they are because they haven't been vetted, so it's tough to know. But since it's not medically beneficial, you want to try it, there's no downside to CBD. Otherwise, don't waste your money. It's minimum 20 bucks, more like 100 bucks. And if you think it works, it's because it's all in your head, which is also fine, because pain is also all in your head because it's a subjective thing. So whether you break your leg, you still need a brain to say, ouch, that hurts. And so I'm not saying you're faking it, because that's my usual talk when I see patients, but it's in your head. Whatever you can do to make it better, your brain has to be willing to accept that. And that's one of the largest barriers when we're treating complicated pain cases. The patient is not willing to accept pain relief. Maybe it's a sick role, maybe it's part of who they've become, and it makes it that much harder to treat, which probably leads us to the next slide. The most effective way to treat pain is to make you convince yourself it hurts less. And you can't just say it hurts less. It doesn't work. Stub your toe and say, oh, I didn't do it. Although it's very easy to distract yourself, because you could punch yourself in the leg, not where you hurt, but distract yourself from the pain you have somewhere else. How can you train your brain to accept less of the pain signal from the area that hurts? It takes a lot of time. It's usually very expensive. It's usually poorly covered by insurance, but it is the best treatment we have. It's toughening you up from the inside out. I like to equate it to Navy SEAL training. These guys are out on a mission and they get shot. And what do? And they keep going and they finish their mission, and then they come back and they break down and they cry and they say, wow, it really hurts. I got to do something about this. They're trained not to have that pain at that time because it doesn't benefit them or their mission or their team. They're trained. It's a lot of training. It's the military. They can do that. We don't get to do that day to day. There are people who have a high pain tolerance. It's genetic. It's who they are. It's their training. It's who they've become. And there are folks like me who I sprained my ankle and I'm crying and lying on the floor looking like a goofball. And so everyone has a different tolerance to pain. It's whatever you say it is, and that's fine. But clinical psychology is the best way of treating the pain. It's just hard to find someone who knows what they're doing. It's hard to get it covered through insurance, and it's very time consuming. So while it's the best thing we have, it's the least thing we do because it's got the most barriers to making things better. And I think next slide is no slide. So yay, I finally get to stop just talking and talking, because again, this is a 3-hour lecture. I probably cut it down to just about 30 minutes. Whew.
All right, Kara, so we're ready to take some questions and see if we can provide some answers.
All right, I'm off mute and I'm unmuting Margaret as well. I do have some that I received. Margaret, did you receive any questions?
I have not yet.
Okay, let me get to my chat. All right, one of the questions, why is there a high risk of heart attack and stroke with NSAIDs?
Is a very simple answer because that's what's been studied. The mechanism is the cyclooxygenase enzymes. There's several subtypes, COX-1, COX-2. It's where those receptors are represented in the body, that when they're blocked, they change the viscosity of blood and they can lead to clot formation in the heart or in the blood vessels going to the brain, causing a heart attack or stroke.
I just want to add to that too. It really, for some of these medicines, it's really a shame that that was one of the side effects. I remember when Vioxx came out and I was, I believe, doing my adult year of neurology. It was around 1999, 2000. And one of the headache doctors in particular loved Vioxx. It was very, very effective for headache. And when it was taken off the market because there were a very high number of heart attack and strokes associated with Vioxx, a lot of headache patients had a huge struggle finding an alternative because it was extremely effective as a pain medicine.
Okay. There was another question. We were wondering what you thought of dantrolene if other muscle relaxers don't work very well for muscle spasms.
Yeah, so we haven't talked about dantrolene that much. Dantrolene is a drug that is, again, it's a very old medicine. I think that the most common use that I know is when somebody has malignant hyperthermia and they are in rigid muscle spasm and they're actually in rhabdo. Their CK goes very high. They might have a fever, and that's the arena that I was the most familiar with using dantrolene. One of the anesthesiologists at Children's Hospital in Pittsburgh started teaching me that dantrolene actually, prior to it being used in malignant hyperthermia acutely, was actually used in spasticity for years prior to its use acutely, and it was used on a chronic basis. I know that when you give it orally instead of IV, it can take weeks for it to build up in the system, and it's apparently very good for spasticity. I'm going to ask Dr. Lobel if you've ever heard of using dantrolene for spasticity or pain. Is that a med you're familiar with using?
Used it on occasion, probably 10 patients in the last 10 years. 25 milligrams is the dose, 2 to 3 times daily, typically 3 times a day. It's known through dogma, which is what we're taught as we grow up as doctors, as well as education, what's in our books and in the journals, that it's one that requires more frequent liver enzyme testing, especially in your elderly female patient, that it's potential to cause liver failures there. And so when you're taught that to start, you're less likely to prescribe it, except in younger and healthier patients. And then you typically don't want it to work because you're the only one prescribing it. So it's rarely used, but it is a good spasticity medicine. Just really want to do every 3-month liver enzyme testing, and maybe in a mitochondrial patient, that's getting done anyway for any number of reasons. So then it's one medicine to look at, although most of the muscle relaxers, all but Robaxin, you need to follow liver enzymes because they can all be part of elevated liver enzymes where if it's 3 times normal, that medicine gets stopped. But it's effective. And the only time I've seen it used with malignant hyperthermia was in med school in my rotations, and it was 0 for 1. The patient just didn't make it. And I don't know how widely used it is. I mean, it's just a rare condition for malignant hyperthermia.
Right.
I've only seen it once.
Right. So for chronic pain, though, do you think there's a certain patient, like a what type of patient do you think dantrolene is going to serve best? Somebody who has longstanding spasticity?
Only in
Only in
spasticity. I wouldn't use
spasticity.
it as a muscle relaxer, and I will have had them failed Xanaflex and baclofen. If they failed those two, this is my only option versus benzodiazepine, which can be used, typically Valium. I don't prescribe the class benzodiazepine for regular use. I'm just not comfortable with it, especially as a pain physician. If you are writing a large amount of benzodiazepine, the government looks unfavorably on you, because I'm usually the guy in the government who looks unfavorably on those other doctors for writing too much of that medicine, especially when you combine it with pain medicine.
Okay, another question. If there isn't a mito doctor nearby to treat pain on a more regular basis, what kind of specialist would you suggest for a person with mito who has chronic pain?
So chronic pain is easy. You want to go see a pain specialist, and that's anyone board certified in pain medicine. That's either an anesthesiologist or a physical medicine rehabilitation doctor, such as myself. And with mito, it's a muscle, it's a energy disease, but predominantly musculoskeletal and nerve related. I would 10 out of 10 pick the physical medicine rehabilitation doctor, because they'll be more familiar with these types of patients, whereas the anesthesia pain doctor will have never seen them. Only because rehab medicine training, we get to start out in the NICU, follow through pediatric rehab, muscular dystrophy clinics, where in the university center, if they don't have a mitochondrial disease specialist, I would imagine you're in muscular dystrophy type clinics will be the kind of the catchment there.
Yes. Yes. And just as a reminder, some of the mito doctors that, especially in the US, are geneticists, and I don't know how comfortable many geneticists would be in treating pain. So I agree. I think that, one of the things that we'd like to really focus on with any symptom is that if a patient is seeing a mito doctor, that's wonderful, because usually the mito doctor is going to know what syndrome or how to do the testing or to talk about supplements. But if you're having certain symptoms from your mitochondrial disease, it really would benefit each patient to go and see a specialist that is an expert in treating that symptom. So if you have headaches, you may need to see a headache doctor. If you have pain, you need to see a pain doctor. If you have migraine, you may need to see a migraine doctor. I probably used that one already. If you have GI symptoms, you need to see a gastroenterologist. If you have cardiac symptoms, you need to see a cardiologist. So pain is exactly one of these symptoms that there are specialists that are available. They're much better versed in treating pain and what the current pain management strategies are than a geneticist or a neurologist that you might see in your mito clinic.
Okay.
I would add in that if you're seeing a pain physician, you want to make sure they're comfortable with mitochondrial disease. And the only way to find out is when they're done the consult and they've met you as the patient, call my mito doctor. Because if you can't talk to the person who knows the disease, you're not going to be able to help the patient out as well.
Okay. All right, this one's a little bit longer. Let's see. My daughter has mild mitochondrial disease with congenital myopathy and small fiber neuropathy, which cause daily chronic muscle pain, cramps, spasms, and neuropathy pain. When she has extreme pain, especially after surgery, the opioid type pain meds don't work. Hydrocodone, Vicodin, etc. After we try the big meds, we have to discontinue them because they just don't work and do the opposite and prevent sleep. Is this common? Is the first question. What do you suggest as an alternative? And then if you want to answer that first, I'll go on.
Yeah,
she has more.
So it's case by case. It's usually trial and error. The right thing is hydrocodone, oxycodone, hydromorphone, or traditional short-acting pain medicines post-op. If someone's intolerant to those, and it's not uncommon, 10 to 15% of patients post-op will not tolerate these with or without mitochondrial disease, nausea, vomiting, itching, rash. There's a lot of common side effects from these medicines. Then it's like, oh, we can't use those. What do we do? Well, maybe we go with a different class of pain medicine. That's where the buprenorphine, Butrans, or Belbuca, even though they're long-acting, might be good options. ketamine is always an excellent fallback for opiate intolerant patients because it's a pain medicine that's not an opiate that is strong enough in the post-op period for musculoskeletal pain to be helpful. Additionally, the anti-inflammatories, as long as the doctor will allow, as long as the Mito doctor said, yes, they're fine for this, and there's not kidney or structural issues or bleeding issues, that anti-inflammatories do as good a job as pain medicine post-operatively.
Okay, she did say for daily chronic pain, her daughter takes tizanidine, Aleve, and plus an amitriptyline. I can't even say it right, for migraines.
Mm-hmm.
So I think she's more concerned about what are the long-term side effects, or what are the long-term side effects of these?
I can't speak as to pediatric use of the Aleve. It's over the counter, but probably prophylactically need a proton pump inhibitor just to protect the GI tract from ulcer. Other than that, the heart risk, stroke risk is so low, where what's the incidence of heart attack in if she's 10 years old or 15 years old? Is it 1 in 10 million, 1 in 20 million? If you increase that risk 31%, so it's 1 in 5 million, it'll be a never realized risk. It's not an issue. It's what's the side effects that I may see that I have to look out for. But if Aleve works, that's great. Tramadol has lower dose Ultraset, which I think is fine because it's really not a narcotic. It's opiate-like and a reasonable option. But we're talking in a kid, is there going to be tolerance? Is there going to be dose escalation? Typically, no, not with Tramadol or Nucynta.
So just to kind of comment about this also, so amitriptyline, Kara, I believe is the third medicine that you were talking about, and amitriptyline is a wonderful medicine for headache prevention. It can help people sleep. In some cases, it can be helpful for GI issues, so cyclic vomiting, abdominal migraine, chronic abdominal pain. I have had some patients that when they're on amitriptyline, their motility can actually get a little bit worse. It can cause constipation, it can slow down motility. And so for Mito patients where they don't just have one symptom, you know, on average there are 16 symptoms that patients might have, we really have to keep everything in balance. So amitriptyline can be used, but again, you have to make sure it's not worsening something like abdominal function. And then the second issue is that if somebody's having headache, they should not be taking any acute pain medicine for headache every day. So if I am taking care of somebody with headache and they're on amitriptyline, and then I find out they're using Aleve every single day and still having daily headache, one of the things that we know for headache patients in particular is a lot of rebound or medication-induced headache. And so again, there's a balance between making sure you're not using acute pain medicine every day. And that, it could be Tylenol, it could be ibuprofen, it could be Aleve, it could be the triptans that Dr. Lobel mentioned earlier. You cannot be using acute pain medicine every day for migraine or you will cause more migraine. So that's a really common problem that people get into. And many times people never even tell you not to take acute pain medicine every day or it can make your headache problem worse. So headache is a little bit more of a separate category. I think we've really been talking more about nerve pain, and this, as you mentioned, when you first started telling us about this patient, there's some small fiber neuropathy and muscle spasms. So, you know, again, there's a lot of different pain issues happening in this one particular patient. And so we have to try to balance all that medication. It can be tricky.
Thank you. Margaret, do you have any questions coming in on your end?
I don't.
Okay. And really, I had several questions that were submitted earlier that I had sent to you, Dr. Goldstein and Dr. Lobel, but I think you addressed that they were all centered around the CBD oil.
Yes.
And I think you addressed all of those. So any of the questions that were submitted ahead of time, I think were pretty much addressed already. Are there any last thoughts to share with the patient families while we're on here?
Any last thoughts from you?
Happy Thanksgiving.
Happy Thanksgiving, yes. Well, we will have this available as a recording. We did have a few people that had some problems logging in, so at least we will have it available post-meeting, and we'll share that with our community. And I just can't thank you enough, both for taking time out this week before the holiday hits. Don't eat too much, everyone, but enjoy your family and friends this holiday season. And with that,
Thank you very much.
all right. You all have a very good evening.
Thanks.
Thanks. Bye.